Hi, folks. If we could have your attention, please. I'm John Rossi, and it gives me great pleasure to introduce our speaker this afternoon, Helen Tobon, who is originally from the Republic of Georgia. As you all know, it used to be part of the Soviet Union, where she received a nursing degree prior to her immigration to the U.S. She then completed pre-medical education at San Francisco State University. Then she graduated from Kigeze International School of Medicine in Great Britain and currently is in her final year of residency with our department at South Campus. Her professional interests include general adult psychiatry with an integrative approach, and she hopes to practice this after her graduation. She is also excited to be welcoming a new addition to her family shortly before she graduates, presumably after the end of her lecture, and is looking forward to an exciting career as a psychiatrist. And as you see, her topic is Holistic Healing for the Mind, an integrative approach to psychiatry.
Well, thank you, Dr. Rossi, and thank you, everybody, for coming. Welcome. So today, I will try to introduce you to a different approach to psychiatric patient care in the ever-evolving field of psychiatry and medicine, which is integrative psychiatry. I chose this topic because I am very passionate about integrative approach, because in my opinion, it provides a different but better understanding of mental illness, and I believe or hope that it will eventually become the future of psychiatry. So I'm hoping that today's presentation will offer some conceptual framework for understanding the development of integrative psychiatry, and will also introduce several treatment innovations which can become a part of the integrative approach to mental illness. So, often today when we talk about mental illness, say depression, we often see that normal changes in mood may be labeled as depression, leading to an overdiagnosis of the condition and unnecessary treatment, sometimes with medications. But even if the patient is truly depressed, the prescribed treatment is almost always limited to potent medication. And as a result, a complex, a multifaceted problem in that case is frequently treated with an oversimplified, expensive therapy that is often ineffective. And unfortunately, our medical system makes it difficult for doctors to spend enough time with patients to make a correct diagnosis and to craft truly individualized treatment plan. So also patients themselves often demand the drugs that they see advertised, and doctors frequently go along with that. But there is also another reason for this situation. Many physicians are not trained in other treatment options for depression or anxiety, though this can be safe, inexpensive, and highly effective. So even if both physician and patient favor an alternative to drugs, they often lack the knowledge to employ it. And that is not to say that drugs are unnecessary. In fact, they often play an important role in management of several mental disorders, but they should be viewed, in my opinion, only as a component of care when needed, and their usefulness should be evaluated regularly while also addressing other aspects of the patient's life, such as diet, exercise, stress, activity level, relationships, and other factors. So historically, non-conventional approach to treatment was actually popular, and the patient was more important than the disease. The patient was more important, and there was an emphasis on prevention of the disease with non-pharmacological measures, such as diet, for example. But the model of conventional medicine today, and it has been for years, is a biomedical model which emphasizes fighting the disease, and the treatment is specific to illness and not the person. And this paradigm works great for treating infectious diseases or traumas, but when condition is chronic, non-infectious, non-mechanical, and often multifactorial in etiology, this model has limitation and will have poor results. So when it comes to psychiatry, we often follow a biomedical model, separating the mind from the body, because of the conventional medical school training, discovering biomedical etiologies for mental illness, and creation of powerful psychotropic medication that treat mental illness on the basis of it being the result of neurochemical imbalance in the brain. But we should also remember that René Descartes argued that the mind interacts with the body and promoted thinking that resulted in current mind-body dualism, which proposes that the mind controls the body, but the body can actually influence otherwise rational minds, such as when people act out of passion. And so there is a lot of connection between mind and body, and therefore that cannot be treated independently. So unfortunately, or maybe perhaps fortunately, when a lot of chronic medical conditions arise, and when people become dissatisfied with their biomedical approach because it doesn't address those conditions well, people begin to search for alternatives and increasingly begin to consider other therapies, including ones from other parts of the world. And this way, complementary and alternative therapies begin to emerge. So according to the NIH definition, these are the healthcare system, practices, and products that are not presently considered to be a part of conventional medicine. So again, they're subdivided into complementary and alternative. And complementary is not mainstream, but it's congruent with the dominant model, let's say herbal medicine, and used together with the conventional medicine. The alternative medicine is at odds with dominant model and is not mainstream, let's say acupuncture, and is used in place of conventional medicine. But integrative medicine is not synonymous with complementary and alternative medicine. It actually combines the mainstream medical therapies and COM therapies for which there is high-quality scientific evidence of safety and effectiveness. And it is a healing-oriented medicine that takes account of the whole person, body, mind, and spirit, includes all aspects of life. It emphasizes the centrality of the doctor-patient relationship and focuses on least invasive, least toxic, and least costly methods to help facilitate health by integrating both allopathic and COM therapies. So integrative medicine is basically the best of both worlds. And it can promote ultimate health, which by the WHO definition that we saw earlier is a complete state of physical, mental, and social well-being, and not just merely the absence of the disease. So what is integrative psychiatry then? It actually refers to ongoing efforts to combine the best evidence-based conventional and best evidence-based COM therapies while emphasizing the primacy of the patient-physician relationship and the importance of patient participation in his or her mental health care and disease prevention. It takes into consideration all factors that influence mental health and uses natural, effective, and less invasive interventions whenever possible. And I think psychiatry is very uniquely situated to use the integrative approach. Actually, most doctors who use integrative approach with patients are psychiatrists, as opposed to family physicians or internists. And this integrative approach supports the person's resilience and facilitates the innate healing response at the level of the mind, body, and spirit. Because we as doctors do not really heal anybody, since healing comes from within, but we can always facilitate that healing. So why complementary and alternative medicine is relevant to psychiatry? Well, today, 72 million American people use at least one of those therapies for medical or psychiatric disorder, and people with any psychological or psychiatric disorder use it even more. So there is greater use among those people. And in one relatively recent study of outpatient population, showed that 60%, which is more than half of severely depressed patients, used complementary and alternative therapies while taking their regular prescriptions. But not all of the patients disclose their use to a family physician or a psychiatrist, and that due to many reasons, and that can lead to different problems like treatment failures or delays and safety issues. So the average user of the complementary and alternative medicine is usually better educated than a non-CAM user and has a holistic orientation to health. And so the mental health professional should know which CAM are safe and effective and which are unsafe and ineffective to be able to provide judicious advice to their patients and refer them sometimes to other appropriate CAM practitioners in order to limit their liability. So, for example, in one study in 2004, about 25% of patients reported that their regular conventional medical provider suggested using alternative medicine. And usually people are not opposed to the conventional treatment because more than half of them used CAM combined with the conventional medicine, and they thought it would be helpful. And another half thought it would be just interesting to try, but almost a third of the population thought that conventional medicine would not help. But more people thought the combination would be ideal. So the complementary and alternative medicines can be broadly classified into the following categories. And as you can see, any of these complementary methods can be integrated into the standard psychotherapeutic practice, although some lend themselves more than others. For example, hypnosis is used by psychiatrists for a variety of disorders, and dynamically oriented psychotherapists use hypnotherapy to enable patients to recover feelings or memories that are repressed and otherwise not available for analysis. So patients with somatoform disorders or eating disorders who have major body image distortion can often be helped by CAM techniques that involve body manipulations, like say, craniosacral work or massage, or some patients that cannot tolerate being touched, which is a trait that is almost always related to some past traumatic experience, can use body manipulation to help correct those abnormalities. So let's look at more detail into some of these treatments that can be used in psychiatry to help most common conditions. And today we'll just concentrate on depression and anxiety. So we can see here listed several complementary therapies. Some of them are nutritional, vitamins, or others are not, and a lot of these therapies have substantial evidence about their effectiveness that was observed throughout the years. And the recent study that I reference here, in this study, the PubMed was searched from 1966 to 2010 for the results and references to identify clinical trials, meta-analysis, and reviews for specific CAM therapies in relation to major depressive disorder. And in all of these therapies, the HAM-D scores were reduced, either as using them as monotherapy or adjuncts to conventional treatment. So let's look briefly at some of them. So St. John's wort we all heard about. St. John's wort, and it was found to be equivalent to a low-dose tricyclic antidepressants in mild and moderate depression. The large trials found it to be much more significant in effectiveness compared to the placebo, but mostly for the mild and moderate depression, and that's how it is recommended today. Because for the moderate to severe depression, there were 2 trials, randomized placebo-controlled trials, that did not find much difference between St. John's wort and placebo. However, in this particular study, there was also study done on moderate to severe depression, and paroxetine was compared to St. John's wort, and it was a similar effectiveness found between paroxetine and St. John's wort, but patients actually better tolerated the natural substance. So in terms of safety issues, of course, St. John's wort should be cautiously prescribed because it has a lot of drug-drug interactions, since it induces P450 and may reduce serum levels of many different medications, including oral contraceptive pills or anticoagulants. But it is found to be very effective for mild and moderate depression or dysthymia. So folate, we know all about that it's a folate is a supplement and a vitamin that we consume in food. And these 2 vitamins are involved in the production of neurotransmitters, dopamine, norepinephrine, and serotonin, through the synthesis of SAMe. And folate deficiency is associated with, appears to correlate significantly with the higher rates of depression, cognitive decline, and memory loss. So as you can see, between 31 and 35% of depressed patients were shown to have borderline or low folate levels in this recent study. Data also suggests that low levels of folate may hinder the response to antidepressants. So if you are deficient in folate, not only will you be depressed, but you will also not respond well to antidepressant medication. Significant reduction in symptom severity in non-folate deficient patients was also found when they supplemented with folate. And it makes sense then to supplement, because in this other study, the 2 randomized groups, one with fluoxetine and placebo, and the other one fluoxetine and folate, the one with folate improved more, and especially women in that group improved more than men. So supplementation becomes important in folate deficient patients, but can also help non-deficient patients who may be partial respondents or non-respondents to treatment. And in subgroup of population, those with alcoholism or elderly patient and patients with dementia, monotherapy also may benefit because it prevents the cognitive decline, and usually alcoholics are deficient in B12. So more studies are necessary to estimate the precise dose, but so far the research suggests that folate in 400 micrograms to 1 milligram a day is safe. So I also want to talk about this supplement or nutritional substance. Actually, it's a naturally occurring molecule which is present in all living cells, SAMe. And it is involved in the metabolism of dopamine, norepinephrine, and serotonin, and is a natural antidepressant. One of the best studied supplements, actually, that was shown to be effective for treatment of major depressive disorder in 16 open trials, 13 double-blind placebo-controlled trials, and 19 double-blind control studies in comparison to standard antidepressants, especially tricyclic antidepressants. So SAMe is more like a vitamin, so it's very low in side effects, and they're usually mild and may include some anticholinergic effects such as insomnia, constipation, nausea, dry mouth, or sweating. It doesn't cause any weight gain or sexual side effects. And it is an activating antidepressant. It's more like Wellbutrin, so it has to be cautiously prescribed in people with bipolar disorder because it can trigger mania or hypomania. With SAMe, actually, you can treat a wide range of depression from mild to severe. And it was also studied in relation to relieving pain from osteoarthritis and also was found to be beneficial. So if, for example, patient has depression and arthritis or fibromyalgia, you can use SAMI very effectively. Okay. Essential fatty acid, omega-3, EPA, and DHA. So we all know the general health benefits of omega-3, especially cardiovascular benefits, such as decreasing the risk of thrombosis or arrhythmias, reducing inflammation, atherosclerosis. But there are also major determinants of membrane fluidity in synaptic membrane involving in a synthesis, binding, and uptake of neurotransmitters. And data suggests that deficiency of omega-3 fatty acid or substitution of omega-3 with omega-6 in the cell membrane is associated with unipolar or bipolar depression, possibly due to the loss of this membrane fluidity and consequently change in the neurotransmission. And worldwide, omega-3 fatty acid deficiency has been associated with depression. It has also been associated with the increased risk of suicide, as shown in a very small recent study of only 33 patients who were not on any medications, but 7 of them attempted suicide, and they were found to have low levels of omega-3 fatty acids. The studies did not show that efficiency, didn't show that as a monotherapy, the DHA or EPA would be effective, because they didn't show much benefit over placebo, even though it did show the benefits in a childhood population. So it makes more sense to use omega-3 as adjunctive treatment in unipolar or bipolar depression, not as a monotherapy. And this recent trial also showed when people were randomized into 3 equal groups. One was just treated with EPA, which actually considered more critical than DHA for mood disorders. The other group was just treated with fluoxetine, and the third group was treated with EPA and fluoxetine. So the groups that were just with EPA and fluoxetine showed similar efficacy, but the one with fluoxetine and EPA showed to be superior to either of them alone. So omega-3 fatty acid may also reduce oxidative damage and slow age-related cognitive decline. They help with childhood depression, and it is a reasonable treatment option for a subset of patients who have depression but also are at risk of cardiovascular disease. So for pregnancy and postpartum, it can be safely indicated because, first of all, it has good benefit for maternal and fetal development, brain development, but also in some of the studies was found to be superior to the placebo in pregnant women who had major depressive disorder. Okay. So now we're shifting from nutritional and herbal supplements to some somatic modalities, and exercise is one of them. And multiple treatment studies demonstrate benefits of aerobic exercise and even resistant training on mood. So it was actually found to be equal to 30 minutes of exercise a day was found to be equal to CBT and superior to several SSRIs. Epidemiological findings also suggest that regular exercise is associated with decreased prevalence of depressive episodes in older adults, patients with concurrent medical problems, and in patients with chronic depression. So if exercise on mood can actually be sustained over time, but it is hard to do a very good clinical trial with exercise just because it's hard to maybe blind the experimenter with regards to group that are not exercising, and so more long-term longitudinal studies are needed in this area. So basically we talked a little bit about some of the modalities from complementary and alternative medicines that we can use to have an integrative approach to depression. So in that case, integrative approach will start with good thorough history taking, including patient's nutritional status, comorbid physical disorders, medication side effects, substance abuse, and we can also inquire about patient past or current use of complementary and alternative medicine and their preferences. Then we can do some lab studies to investigate whether they are deficient in vitamin B or folate, or also vitamin D levels. Even though I didn't talk about vitamin D, it was found to be beneficial in people with depression, so supplementing with vitamin D. We can also inform patients of options for standard treatment and for complementary and alternative treatments and see where they are with that. And then if we have all this information, it will be better to then incorporate all this knowledge into the treatment, and the treatment will become more integrative rather than just prescribing one antidepressant and sending patient home. So we can correct nutritional deficiencies through dietary education and supplements. If the patient has incomplete response, if a patient is already on antidepressant and has a complete response but no side effects, then we can consider either increasing the dose, switching to a different antidepressant, or even augmenting with one of those complementary and alternative therapies. And for patients who failed numerous medications trials, we can actually start with complementary and alternative medicine. We can start trial, let's say, with SAMI, which is a natural antidepressant. And of course, we shouldn't forget about psychotherapy and other mind-body therapies. So integrative approach to depression then becomes summarized in this nutritional, somatic, and mind-body approach. So again, with nutritional, we can correct the deficiencies, introduce some of the supplementation with vitamins or SAMI, and use St. John's wort. And the somatic approach would be exercise, phototherapy, even though I didn't talk about the phototherapy, but light therapy is effective in some seasonal affective disorders. And also look in other aspects of patients' life, such as sleep, play, whether they are connected with nature and people, because that also helps a lot to improve mood, specifically depression. A mind-body approach, so psychotherapy or hypnosis. Okay. So anxiety. So on this slide, again, we see kind of an overview of some of the complementary or alternative treatments that are used for anxiety. And actually, this can be used not necessarily for patients who have the diagnosis of generalized anxiety disorder, but also for people who experience anxiety in different kind of social situations, like dental appointment or upcoming surgery, exams. And the most, I think, majority of people who use complementary or alternative therapies are patients who have some sort of anxiety, and it is a very prevalent disease, as we know. So, for example, kava and L-theanine are substantiated by research for generalized anxiety, and in the recent systematic review that I cited here, the review was of specifically nutritional and herbal supplements. 24 studies, including a total of 2,619 participants, were analyzed. And of the randomized control trials reviewed, 71% show the positive direction of evidence. So this herbal and nutritional preparations are very efficient, very effective in treatment of anxiety. And there are, of course, other modalities such as meditation and mindfulness training, virtual reality graded exposure therapy, which is a rapidly evolving modality and will play a significant future role in the treatment of many anxiety symptoms, including those of social phobia, specific phobia, and panic attacks that are poorly responsive to conventional psychological and pharmacological approaches. Also, acupuncture is widely used for anxiety. Now, the modalities that you see on these slides, there are many of them, but there is very limited research findings and only anecdotal reports and inconsistent evidence that suggests that these treatments of anxiety very effective in some cases. And they are used by many complementary and alternative medicine practitioners. Most of the trials, of course, are mainly observational because, again, it's hard to do randomized placebo-controlled trials with these particular modalities. So just like we did with depression, we can take a look at some of those complementary and alternative treatments in the treatment of anxiety. So today, most evidence exists for this herbal remedy, which is a traditional social and ceremonial drinks in the Pacific Islands. And it interferes with the norepinephrine reuptake and binds to GABA and MDA receptors, both of which modulate anxiety. So Cochrane's systematic review of 11 controlled double-blind studies, including 600 patients, concluded that kava was superior to placebo for the short-term management of generalized anxiety. And the finding of small double-blind controlled trials suggests that generally anxious patients who gradually increase their daily dose of kava while, let's say, tapering off of benzodiazepines do not experience worsening anxiety and benzodiazepine withdrawal. So it can be used in patients who want to taper off their benzodiazepines as an adjunct and help them avoid withdrawal symptoms or worsening of anxiety that is usually happening with benzodiazepines. And unlike benzodiazepines, patients who take kava do not experience mental slowing or impaired cognitive functioning. When kava is used at recommended dosages, which is between 60 and 300 milligrams a day, patients do not experience these symptoms here, like I said. And kava is generally well tolerated, but it may have uncommon adverse effects such as GI upset, rash, headaches, and dizziness. It does cross-react with benzodiazepine, and it may increase sedation if it's taken concurrently. But like I said, if we increase the dose gradually, starting slowly, and taper off the benzodiazepine, that should not occur. The kava doesn't potentiate the effects of alcohol consumption in humans, but there were some cases of hepatitis and liver failure that were identified, and because of that, kava was, I think, taken from the market in Europe and other countries, and here in America it has a FDA warning. However, independent experts have concluded that most reported cases of liver failure were associated with a processing mistake that resulted in the toxic levels of alkaloids in a single batch of kava. Because, for example, people in Pacific Islands, they use kava regularly in high dosages, and they've never seen a liver failure or hepatitis in those countries. But nevertheless, it is judicious probably to advise patients against taking kava if they have a problem with alcohol abuse or pre-existing liver disease, just to be on the safe side. So other herbal remedies, just briefly, that were used for ages for anxiety and insomnia, such as valerian root, for example. It is not a benzodiazepine, so there is very little abuse potential with that. It also should be avoided if there is liver dysfunction, but 6 of 7 studies found it statistically significant and those related sedative effects, so it can help with insomnia a lot. Another herbal supplement, which is rhodiola rosea. There were many classified Russian studies during the Cold War that show that it can enhance cognitive performance under stress, and it also reduces mental fatigue, improves overall well-being, but it has to be used cautiously with bipolar patients or patients who had myocardial infarction. Okay, another nutritional supplement now, moving away from herbal, that's the L-theanine, which is found in your green tea. And a purified L-theanine extracted from green tea is widely used to treat anxiety symptoms and depressed mood in China, Japan, and other Asian countries. The calming effect of L-theanine are said to compensate for the stimulating effect of caffeine in green tea. And the anti-anxiety effects are achieved through enhanced alpha brain wave activity and decreased synthesis of GABA, resulting in general feeling of calm and well-being. So calming effects usually are noticed within 30 to 40 minutes after ingestion of between 50 to 200 milligrams, which is about 3 to 4 cups of green tea, and typically last 8 to 8 hours. Moderate anxiety often improves with 200 milligrams once or twice a day, but it can also be used for severe anxiety and, of course, will require higher doses, up to 600 or 800 milligrams daily, but, of course, it will be taken in little increments of 10 to 200 milligrams spaced over the course of the day. And unlike benzodiazepines, L-theanine doesn't result in increased drowsiness, slowed reflexes, or impaired concentration. And there is no risk of developing tolerance or dependence, and there have been no reports of serious adverse side effects or interactions with other natural products or conventional synthetic drugs. Okay. So we talked about nutritional supplements, herbal medicine, and now moving to somatic or mind-body exercises. And they can result in significant improvement of anxiety levels, which are equivalent or comparable to antidepressant effects or effects of cognitive behavioral therapy. So some of those relaxation techniques are yoga, guided imagery, mindfulness meditation, or progressive muscle relaxation. So yoga, we all know that it's practiced widely, not only in Asian countries, but now probably throughout the world. And regular practice reduces need for conventional medications in patients with generalized anxiety disorder. It also significantly reduces symptoms in obsessive-compulsive disorder, but there is a special type of yoga, I think it's called Kundalini yoga, with the left nostril breathing. But it causes sustained changes in brain activation and doesn't have any absolute contraindications. Guided imagery is a self-directed treatment through visualization, has beneficial effects on the immune system, physiological stress response, and cognitive emotional functioning in general. It is often used in people with cancer patients, and help them with their immune system. Mindfulness meditation is a self-regulation of attention. So patient practices detached self-observation, and it shows beneficial physiological effect with decreased oxygen consumption, respiratory rate, blood pressure, and autonomic arousal. And progressive muscle relaxation basically has relaxation in its name and can be used in patients who may not like yoga or do not want to meditate or have hard time with guided imagery. So I mentioned virtual reality graded exposure therapy before, and it is a therapy that is used for anxious or phobic patients who frequently unable to tolerate conventional kinds of exposure therapy and therefore remain chronically impaired because they never become desensitized to a feared object or situation. And virtual reality-graded exposure therapy is more effective than conventional exposure therapy and is better tolerated by these people. Was also shown to have comparable efficacy to in vivo exposure therapy. So it's sort of equal to exposure therapy, but it's better tolerated by patient and probably will improve the response. In one study, between where VRGT and conventional CBT were compared, they also had equal effect in the treatment of panic disorder with agoraphobia. However, patients who underwent virtual reality exposure therapy required 33% fewer sessions to achieve the same results. It's an effective therapy for many anxiety symptoms, including specific phobias, generalized anxiety, panic disorder with agoraphobia, and post-traumatic stress disorder. could be used effectively in people with like specific phobias, like I said, the fear of flying, fear of heights, fear of small animals, etc. And it is cost effective. The tools of this therapy are available online so that patient can use advanced exposure protocols at home through real-life video conferencing. There are some safety issues that should not be overlooked with this particular type of therapy. Approximately 4% of individuals experience transient disorientation, nausea, dizziness, and headache, and blurred vision when in a virtual environment. And quote, simulate sleepiness is a feeling of generalized fatigue that can infrequently occur with this type of therapy. And intense sensory stimulation during VRGT can trigger migraine, seizures, or gait abnormalities in individuals who have already this medical problem, so should be probably contraindicated in these populations. Anxious patients who abuse alcohol or narcotics should not use this therapy. And of course, psychotic patients should not use the therapy because of the immersion in the virtual environment can exacerbate delusions and potentially worsen their reality testing. So let's look at acupuncture. It is widely used in Asia and Western countries to treat anxiety. And it's an Asian Chinese art that involves inserting needles into specific meridian points on a body, thereby balancing flow of vital force called qi in the body and relieving pain or anxiety or other problems. And studies outside China regarding use of acupuncture for psychiatric conditions are very limited and mostly reflect clinical observation rather than rigorous controlled clinical approach. And a lack of ideal placebo has been one major limiting factor. But small but significant risk of pneumothorax can be minimized by using sterile needles and using or having it be done by a clinician with a good grasp of anatomy. It can have rare side effects such as bruising, fatigue, and nausea, but overall has been found to have very good anti-anxiolytic effect. Yeah, so today very few prospective double-blind randomized controlled trials are positive, and most studies on the anxiety-reducing effects of acupuncture basically examine benefits on diverse cognitive, affective, and behavioral symptoms. Well, this is a different modality, which is energy therapy, and one example is Reiki. And it's a system of natural healing techniques, which is administered by laying of hands and transferring energy from the Reiki practitioner to the recipient. Significant relief was observed after the weekly treatments with either contact or non-contact Reiki in one of the relatively recent study, and it provides an overall improvement in well-being, relaxation, pain relief, also sleep quality and anxiety. Of course, findings are limited because of possible unreported differences in the use of anti-anxiety medications between Reiki treatment groups and control groups. So other non-conventional treatments of anxiety, as you can see from this slide, can include dietary modifications or use of amino acid, also exercise 20 to 30 minutes a day, massage, and music therapy. So in terms of dietary modification, of course, avoidance of caffeine and low carbohydrate intake was shown to be beneficial. And amino acids, some of the amino acids that were studied were L-tryptophan and 5-HTP. that are widely used to treat generalized anxiety, but few double-blind studies have examined their efficacy. The 5-HTP is preferred over the L-tryptophan due to greater research evidence and smaller effective dose and increased availability to the central nervous system. The 5-HTP can be safely combined with conventional anti-anxiety drugs without monitoring for serotonin syndromes. Both are essential precursors for serotonin synthesis, and adverse risk is minimized when they are started at a low dose, like 5-HTP, usually started at 25 milligrams a day, and then slowly increased over several weeks. It can be used at a dose of 200 to 400 milligrams at night, and it will reduce the daytime anxiety and will improve the sleep quality in chronically anxious patients with insomnia. So music and sound have been used in many cultures and healing traditions as anti-anxiety modalities, and in randomized study, anxious adults assigned to music-assisted reframing versus cognitive therapy experienced greater reduction in overall anxiety. And of course, massage, probably mediated by decreased cortisol and increased parasympathetic tone, but can be obviously very relaxing and can help with anxiety. So I think I obviously didn't talk about all the possible complementary and alternative medicine that could be incorporated into the treatment of patients with anxiety and depression, but I wanted to give you at least an overview of some to show that they all can be beneficial, and they all are probably very inexpensive and very safe. And that goes for many CAM treatments. They are low-risk interventions which may benefit and will not harm. And I think combining different kinds of modalities, which would be conventional or CAM, is often safer than combining two pharmacological treatments. And all effective modalities in that case should be considered. And approach should be selected based on evidence and relevance to patient need if we want to incorporate it and have an integrative approach to the treatment. And of course, patient must be motivated. Patient must have their preference. And sometimes cost often determines a realistic plan. So in the paradigm of the integrative medicine, I think mind-body interactions are regarded as central to the healing process. And integrative psychiatrists have many more options to offer patients than their conventional colleagues. And as alternative to drugs or as adjuncts, they can recommend all these modalities that I discussed today and can probably bring art back into psychiatry. We know that medicine is a combination of art and science, and psychiatry probably best practiced by incorporating art. I'm sure consumer demands for such psychiatrists are on the rise, but few such psychiatrists are available. So if we want to use the integrative approach in treatment of our patients, we should probably educate ourselves as professionals, either through the books. For example, these books by James Lake, who is an integrative psychiatrist at Stanford, that summarize evidence-based integrative interventions. They may be unknown to many psychiatrists. Or we can use other resources, such as online resources. And here in Arizona, there is a Center for Integrative Medicine that also has fellowship, integrative medicine fellowship, that people can do to improve their knowledge. And we can also remember the old Latin quotation that says that the sound mind resides in a healthy body. And maybe it will help. Thank you. Yeah.
I have a question. That virtual reality graded exposure therapy, so you said there are online resources. Do you just Google VRGET and look at your thing?
I think so. I don't have a specific link, unfortunately, but I can look it up. But yeah, I'm sure if you Google it, it will come up as, no? Have you tried?
Just did.
Oh, you did? You didn't?
Yeah.
Oh, okay. Well, I can try to look into it and maybe email you later if I find it. Yeah.
Yeah, I have an anecdote to report in this domain, and that is using vitamin D for seasonal affective disorder. It's been very effective for me and for several friends, but high dose.
Okay. Yeah, I think most of these supplements or nutritional or herbal medicine, they can be used in high doses without any harmful effects. So that's the beauty of it, because they're natural and they usually don't interfere with either medications. But of course, we need to educate ourselves in order to have good knowledge, because sometimes there is an interaction between two different herbal medicines or herbal and nutritional supplement. And if we do not feel comfortable, let's say, prescribing that to patients, we should always remember that there are a lot of therapists, the complementary and alternative therapists like homeopath or other therapists who have done extensive training on these modalities, and we can always refer patients to them, or for other like acupuncture and massage, and of course just like we do with other things. Yeah.
Getting back to the virtual reality graded exposure for phobias in particular, I thought that you were saying that they've been shown to be more efficacious than some of the other forms of treatment, but that's just, I haven't read that. So they've done a lot of studies compared to placebo, and of course they outperform placebo, and they're starting to have a couple compared to in vivo, and maybe they're making similar improvements, so indistinguishable statistically. And then even in the compared to placebo trial, the effect size is similar, but I haven't seen any showing they're better. I know that patients prefer them. They're maybe more readily agreeable, but I don't know about follow-up with like live stimuli. So I was wondering, I didn't see the references. I was wondering if you maybe send me some of those, or did you know some offhand?
Sure. No, I think I didn't. Yeah, I forgot now, but I didn't include them here, but I can look into that.